Welcome to Lecture 2 of Week 2 of Special Topics, the Integument and Wound Care. In this lecture, we will be discussing burns. The objectives for this lecture include describing types of burn injuries, naming common characteristics of burn depth, explaining some common dressings used with burn injuries and their indications, identifying the importance of therapy and types of therapy that can occur in a burn center, describing the preferred positioning of burned joints, and knowing the difference between temporary and permanent wound coverage options. How do burn injuries occur? Here's a nice graph that breaks down the etiology of burn injuries and the distribution of that. It's from AmeriBurn, the NBRA annual report from 2015. Most burn injuries, as you can see, are a result of fire or flame. The next largest group is from being scalded with a hot liquid. Next is contact with a hot object, and then a much smaller portion is divided between electrical, chemical, and an unknown etiology of burns. One of the most common objective measures that you will see in treating patients who have burns is looking at the total body surface area. This is the surface area or amount of their body that has been burned. So there are several ways to do this. 1% equals the size of a patient's palm. There's also a London-Bratter chart. The rule of nines is a general estimation and is probably most often used in general practice settings. A burn center would be much more specific. It's really important to calculate this accurately on admission because this surface area that's burned is used to run the resuscitation, so needing fluids, needing temperature, timing, all that stuff, and also to prognosticate the length of stay and if the patient will need surgery or not. When should a patient be admitted? If they have a 20% or greater total body surface area that's been burned. If you're looking at a child or an elderly person, it's less than that, it's 10%. Or if they have 5% or greater full thickness area, that's where their whole tissue has been burned. Anytime you have burns to the hand, face, feet, or the perineum, that requires an admission, as well as eyes or ears. Because it is a more severe injury and the burns are occurring in organs, any suspected inhalation injury, the patient should be admitted, as well as electrical or chemical burns, or anytime they have associated injuries or they have a pre-existing illness. Most of us do not practice in burn centers, so it's important to know when your patient should be referred to a burn center versus just being treated in a regular hospital or an outpatient center. If they have partial thickness burns that is greater than 10%, involves face, hands, feet, genitalia, perineum, or major joints. If they have third-degree burns, electrical burns, chemical burns, inhalation injuries, or they have pre-existing disorders that complicate medical management. So do they have other major medical things going on? So the take-home message from the last two slides is when should a patient be referred to a burn center? So because there's a lot of overlap in the admission and the burn center criteria, if a burn is requiring admission, most likely they need to be in a burn center. We're going to spend a little time now talking about the specific causes and types of burns: thermal, chemical, electrical, and radiation. Thermal burns can be divided into flame, scald, or flash. So if you look back at the pie graph from the beginning of the lecture, the largest percentage of burns were related to flame and scald. A burn as a result of a flame is characterized by irregular borders and it usually has variable depth. A scald is the most common cause of a pediatric burn, immersion or contact. So think hot bath water, kid pulls something hot off of the stove, that kind of thing. A flash burn is something that was just a really short contact of heat, and it really can result in any degree of burn. With a chemical burn, the damage is proportionate to the concentration of the agent and the duration of the exposure. So if you had something really, really concentrated, like hydrochloric acid or sulfuric acid that was exposed for a really long time, that could be a very significant burn. I often treat patients who have chemotherapy burns, or maybe where they've had an IV infiltrate with a really caustic type of medication or drug in that. Those continue to burn until the chemicals washed off or neutralized. With an electrical burn, the tissue damage is from the current and could be fire if it's ignited by electricity, if the clothing is. This is the most significant injury that is encountered in a burn unit. With a radiation burn, you have damage to skin or other biological tissue as an effective radiation. So this could be thermal radiation, radio frequency energy, ultraviolet light, ionizing radiation. This could be from radiation treatment for cancer. The most common type of a radiation burn is a sunburn. I don't think most people probably think about that. So let's talk about depth of burns. Superficial burn is what's usually referred to as a first-degree burn. A second-degree burn or a partial thickness burn can be several types. It can be superficial partial, it can be mid-partial, or it can be deep partial. And you actually could have one burned area that has multiple depths to it. A full thickness burn is considered a third-degree burn, and a subdermal burn, or below the dermis, is considered a fourth-degree burn. This is the most serious. The depth of the burn depends on the length of the contact and the mechanism of burn. And it's usually described by the degree, or it could be by the thickness. A thickness description is preferred by burn centers because it talks specifically more about the tissue that's involved. I think first, second, third, fourth degree burns don't really capture the variability that can happen in one burn that has multiple depths to it. Here's an example of a superficial burn. It involves the epidermis only. It's not open. There's no drainage. It can be incredibly painful. If any of you have ever had a sunburn, you know that can be really, really painful, especially over your joints, your arms, anywhere you have to try to move. We're going to talk about partial thickness burns. So superficial partial thickness burn goes through the epidermis and part of the dermis. You have intact sebaceous glands, eccrine glands, and hair follicles. So this is one of the characteristic ways of staging a burn is if you see hair follicles, you know that you're a partial thickness. It's usually moist, pink, and it blanches, so it has some capillary refill to it. It's also very painful. Superficial partial thickness burns will heal on their own with proper treatment and proper wound care. With a mid-partial thickness burn, there's papillary dermis involvement. Usually you're seeing eschar, maybe some delayed blanching, so the capillaries are not as effective, and some of them may have been affected as well. Might be pale, also very painful. Can heal on its own, but it is at risk of converting to a deeper burn without proper care. Finally, we have the deep partial thickness burn. Here we have reticular dermis and skin appendages involved. It usually looks very dry. There's eschar, very minimal blanching. Might be painful, but to a lesser extent because we're past some of those nerve endings. Most likely it needs skin grafting in order to close and heal. With a full thickness burn, the entire thickness of the skin is destroyed down to subcutaneous tissue. It does not have sensation, it's dry, it will not heal without skin grafting. Most often you see thick white leathery eschar or black charred skin. Something to keep in mind when talking about eschar related to burns. Most of the time when we think about eschar, it's black or brown. Often with burns, when you see eschar, it's usually a white or a tan color. A subdermal burn involves injury beyond the skin. It involves fat, muscle, or bone. Usually this is a result of an electrical burn or significant exposure to flames. Because you're into fat, muscle, or bone, the tissue damage and the structure damage could affect compartment pressures. These types of wounds will need surgical intervention to close, either with a skin graft, a flap, or if that's not possible, an amputation. So what is the initial wound treatment of burns right at the time of injury? You want to wrap the patient and the burns in warm, sterile sheets and towels for transport to a burn center or hospital. If at a burn center, the cleaning will occur there with bedside debridement in order to fully assess the extent of the burns. Dressings would be applied per physician orders and a burn nurse or specialty burn professionals' recommendations. A big question is always about blisters. Do you keep them or do you debride them? Well, for a blister related to a burn, any blister that's greater than 2 centimeters should be debrided. 2 centimeters is not very big. In addition, any blister that can limit range of motion, so any blistering over joints, is also debrided. So let's talk a little bit about wound coverage. So when we talk about coverage, we're talking about how this wound is going to be taken care of both temporarily and permanently. So it includes dressings and grafting. Temporary wound coverage will be changed or eventually separate and fall off. So specific dressings, a homograft, a heterograft, or biological covers are often used. A permanent wound coverage becomes part of the patient's wound bed. So this would be an autograft, so skin from somewhere else on the patient, cultured cells, or dermal substitutes with a thin autograft. So what about wound dressings? We're going to treat burns similarly to other wounds. Is there dead tissue present that needs to be debrided? More than likely they will use an enzymatic debrider, not necessarily using instruments to debride. Is there an infection present or a high risk of infection? Then you want to make sure that you're using an antimicrobial dressing. Does the patient already have a graft that needs protection but also still now has a wound and drainage that's being cared for? With any time you have a graft, you want to make sure you're using a non-adherent layer. What about exudate? If there's a lot of exudate present, you would want to increase your dressing change frequency or the dressing absorbency to make sure that you're managing that drainage appropriately. So here's a little tidbit about dressings. A lot of you have probably heard about Silvadene. It's been around for a really, really long time. It is not the ointment of choice for burns. The reason is that it inhibits fibroblast formation needed for regeneration of new skin cells. So if you're trying to get something to jumpstart into the healing process, by just continuing to use Silvadene, you're going to inhibit that and prevent that from happening. Silvadene is recommended to be used only on infected burns that are awaiting surgery. Therefore, you're keeping down the bacterial load and keeping the wound bed moist. You're not really worried about wound healing at this point in time because the patient's going to have surgery. Antimicrobial soaks can be used to fight different infections, such as an infection with a multi-drug resistant organism. Examples of these would include Dakin's solution, which essentially is medical bleach, acetic acid, which is vinegar, gentamicin is an ointment, or it can be a solution, and this is just an antibacterial topical solution, or sulfamylon. This is used specifically for ears. There are also some common lotions used on healed burns and grafts that can assist with maturation of new skin, making sure that it stays moist and protecting it when it's fragile. Examples are Dermade, Nutriderm, Eucerin, Uniderm, Emu Oil, or Aquaphor. Let's talk about temporary wound coverage skin substitutes. The first type is a homograft, so from another human or a frozen human cadaver skin. Homografts are used for wound preparation if there's infection or the wound is too deep or the patient doesn't have available skin to donate to themselves. Homografts decrease pain and decrease loss of fluids, and they're kind of the gold standard for temporary closure. They're biologically active, so there is a small risk of disease or rejection. A xenograft means it's from another species. So an example of this is pig skin. There are multiple products on the market that are made of pig skin that can be used for temporary coverage of a superficial burn wound. They might be used to cover a wound that's been surgically debrided. You can put them on at the bedside or in the OR. Usually they're held in place with glue or staples or steri strips. Eventually they fall off like a scab. They don't actually revascularize. They do decrease pain in superficial wounds. An autograft is taken from another location on a patient's body and applied over the burn of the wound. Two types are split-thickness skin graft, and this is epidermis and a portion of the underlying dermis, and this is the most common type used. A full-thickness skin graft can also be used, and this is the full epidermis and the full dermis. An additional step that has to be taken with a full-thickness graft is that the donor site now also has to be primarily closed or grafted. There's less contraction with full-thickness grafts, so these are good for hands and around eyes. So now we've talked about a lot of burn characteristics, how to stage burns, how burns occur, talked about temporary and permanent wound coverage. Where does a physical therapist fit into all of this? Well, a PT role is to manage rehab from injury. So in addition to doing wound care, you're going to be monitoring and progressing their range of motion, their ADLs, their functional mobility. You're going to be providing recommendations, participating in team conferences, and then after discharge from an inpatient facility, you can serve as a resource for the next level of care. It's the PT's job to anticipate deformity and to educate the patient and the family regarding this deformity. PT should be designing their plan of care toward prevention versus correction of a deformity or a contracture after it occurs. PT should make sure they are monitoring non-burned areas that are adjacent to the burn as closely as there are the burned areas. And also, as with all patients that we work with, making sure that they have an accountable piece for their role in their recovery. So what are the components of a PT evaluation when you're working with a patient who's been burned? A lot of the things are similar to what we already ask about in test. Date of injury, was it an inhalation injury, etiology of the burn, past medical history, precautions, orientation. Those are all very familiar to PTs. Handedness is important, especially when we have burns on the hands and the arms. Their prior vision, if they have swelling, their pain, their social history, that's all typical. Things that are a little more specific when you're working with a patient that's had a burn, you want to be 100% sure you are taking exact measurements of all involved joints. At the time you're doing your eval, you most likely will not see much limitation. That will come later, so you have to have a baseline of where you started from and to know that you want to prevent that from contracting. With general strength and sensation, you want to make sure you're doing a full assessment with electrical injuries. And then, as always, testing functional mobility and balance is a component of our evaluation. Just as for any physical therapy intervention, you want to make sure that you have specific goals of your interventions in working with patients who have burns. You want to make sure that you are preserving their range of motion and functional use. You also want to get them back to their pre-burn ambulatory and functional status. Make sure you're controlling edema. We all know the benefits of active range of motion, but specifically related to a patient who's been burned, this is important because it means they're completing it independently. Active range of motion also promotes functional movement, and it gives the patient some control because there's also not as much pain. Active range of motion also reduces edema and increases circulation. It's the best range of motion on exposed tendons except for PIP joints. Active assistive range of motion is preferred, though, for patients who have decreased strength and limited range of motion. It also promotes scar tissue elongation, so if a patient already has scars, or this might be a patient that you're seeing in an outpatient clinic whose burn was a while ago or years ago, this will help that tissue elongate. It's also completed if a patient can't push themselves through range of motion because of pain. They still have to do it if we're going to preserve function, return to normal functional activities. Ways to do this, we already know these, are by using pulleys, towels, a non-injured extremity, or therapist hands-on assist. Positioning is a very important component of therapeutic interventions. It decreases edema, prevents tissue destruction, and maintains soft tissues in an elongated state, therefore preventing contractures. Once the burning has stopped, the healing process begins, and that's when you get contractures. Positioning should continue throughout the scarring process. I think the most important clinical wisdom take-home message in therapeutic interventions for patients with burns is that the position of comfort is the position of deformity. Burns are very painful, positioning is painful, exercises, range of motion is painful. But if you're allowed to be in a comfortable position, this is usually a shortened, relaxed position, and that's where you get contractures and scarring. So if you're there, you're going to have deformity. Please take some time to review this slide. It lists very specific positioning for neck, hands, shoulder, elbow, knee, and ankle burns related to positioning. It's very important that these are followed so that functional use can be maintained. Gait is strongly encouraged for patients who have been burned as part of their therapy treatment. Most patients, our weight bearing is tolerated through affected extremities, but make sure that's cleared with the physician before you would do that. You always want to make sure you're providing vascular support for a limb during ambulation, so making sure you're wrapping from the foot to a thigh with a compressive bandage such as ACE. This vascular support is going to prevent inadequate venous return. So depending on what's affected, the stage of their burn, the tissue that's affected, they may have inadequate blood flow to get back, and if they're dependent enough, they may not be able to do that on their own because of the elasticity or the burn surface. You also can get tissue engorgement if you don't support the vascular system, increased edema, or bleeding. You also may need to warm up the vasculature with pre-gait Therex before you actually get up and move. So think about doing exercises with legs in supine or seated position to get blood flow increased. Patients can ambulate while on mechanical ventilation. You just need to know the equipment and the facility protocols. Using gait belts for patients with burns is sometimes difficult, depending on tubes, lines, grafting, burn surface, that kind of thing. So just ask for extra hands. Sometimes it's good to co-treat with occupational therapy or to use rehab tech or a bedside nurse. As always, you want to work with the rest of the team, including nurses, to disconnect anything that's not necessary while you would be up moving around. Patients who've been burned are at a high risk for developing DVTs, so promoting and encouraging early functional mobility and ambulation is very important. Let's talk about a couple of special therapeutic concerns. The duration of the treatment depends on several factors. Does the burn cross a joint, and how many joints are involved? If you have a patient that has a burn across a joint, you're going to be spending a lot of your treatment on range of motion in positioning. If they have multiple joints that are involved, that's going to increase the length of your treatment because you need to do the same things at each spot. Is the patient unconscious or conscious? If they're unconscious, you might be able to spend a little bit more time because their pain is going to be controlled differently than if they're conscious. And does the patient have full range of motion in the involved areas? If they have full range of motion, you're still going to treat that to prevent it from contractures from happening, but you can focus on other things as well during your treatment. So here we have a nice comparison to inpatient versus outpatient burn management and burn treatment. On the inpatient side, it's more toward the acute injury. So you want to think about preserving and regaining function. You're going to be coordinating with wound care, other therapies. Pain is a huge factor, so looking at pain medicine schedules, surgery schedules, family and patient education. In the outpatient setting, you're going to continue improving the quality of functional movement. You're still going to be coordinating with other disciplines, but it's more as an appointment sort of thing versus the team is all there in one time. So thinking about more things that are related to just life, like splinting schedules, sleeping patterns, what are we doing for scar management, and then just promoting normal social life and increasing independence. So just a little bit different lens between inpatient and outpatient. Probably not that big of a different lens just from inpatient setting to outpatient setting in general, but a few more focused on burn recovery things. This concludes our lecture on burn and wound management. Please refer to your textbook, Wound Care Made Incredibly Easy, for further information, or an additional reference is Wound Management Principles in Practice as well.